Ladies and gentlemen, as you know, my name is HipHopMike, and if there's one thing that I know, it's hip hop. But if there's a thing that I don't know, it's called medicine. So I have one of my best friends in the world who is way more successful than me, but also has way more debt. I'm talking about a guy who has put himself through school and worked his ass off since day one to not just get a degree, but also countless females who slide in his DMs on the daily because he has MD after his name. Mark Faber, ladies and gentlemen.
I love it. I love it.
It feels so great to see you, my friend. How are you?
Good, man. How are you? I can never get a hold of you. You're too busy for me.
Listen, you have my original phone number. You're probably one of the first people I've ever given my phone number to, and you don't even try to use it that often. You never call me or bother me for shit.
No, but I do text you just to check in with you, and I've
didn't
answered your
answer.
calls middle of the night too, if you may recall.
That's a fact. I was at Hot 97 dying, and Faber definitely gave me some medical advice about how.
Yeah, I told you to stop working nights.
and I kind of took your advice.
Yeah, you did. You did, but you called me.
I did, and
I helped you get I think I helped you get your insurance stuff taken care of. You're like, how do I find someone? I'm like, call the insurance number on the back of the insurance card. What is that? I'm like, all right, it's on the top. Try looking on the back side of the 800 number, whatever. So.
Well, whether you are trying to figure out who your best provider is or you're dying from the coronavirus, this is your guy right here. What's up, Faber?
Well, not much. Just living in Buffalo right now. I'm finishing up residency. How about I give a little
Give them some background. Let them know who you are, how you got your scrubs.
So I bought these.
Okay. Not literally how you got your scrubs, like the work that goes into.
Okay, so, all right. So I've known HipHopMike since he was Mike Turkey Turkowitz.
Yep.
We went to Coleman Day Camp together, and I heard that they unfortunately had to cancel their summer season. I'm not sure if you heard about that.
Quiet for the Colemans.
It's terrible. So we met back in 2001. So I'm from Long Island. I went to NYU for undergrad. I worked at City MD Urgent Care for a year. After I graduated, I was a scribe. And that year, that was a bad flu year. I'll never forget that. Then I went to the Lake Erie College of Osteopathic Medicine out in northwestern Pennsylvania. And now I'm up at University of Buffalo for internal medicine for my residency. I'm actually finishing in my internal medicine residency in about a month. Then I'm starting my hematology oncology fellowship, which is basically a mix of solid tumor cancers, blood cancers. That will be at the Roswell Park Comprehensive Cancer Center in Buffalo. So I reached out to you. Yeah.
He's very qualified to discuss what we're going to discuss today.
I have been taking care of COVID patients, yes. So I figured I'd reach out. I did reach out to you asking if you wanted me to, if you wanted to do something to just answer some questions, go over some facts, and because there's a lot of misinformation out there.
That's a fact. And I think that it's super important for that information to get out, especially to people that follow me, because as you know, the underprivileged communities are going through it more so than I think any other community. I mean, that's correct?
Oh, so, yeah, it's correct. Yeah.
We wanted to give you guys the information. We wanted to kind of tell you some things to look for, some facts. But yeah, I mean, what's it been like dealing with a lot of the COVID patients, and how did this hit the hospital for you? I mean, it kind of caught all of us by surprise, but
it caught everyone by surprise. So I remember back in February, like we knew of it. We knew about it. But we didn't really think it would, no one realized it would escalate to this level.
How did you find out about it in February? Was it like that the hospitals were starting to get alerted? Like, what's that chain of command like?
No, I just remember how, there's this virus in China. Yeah, there's this weird virus in China. Okay. And then it was all through the news. That's how I found out. And then I remember how, like, University of Nebraska, they have a top infectious disease program. They were taking some American citizens who were infected to their facility to get treated, and they turned out fine. And that's when everyone was saying, this is just a little flu. You'll be fine. Dr. Fauci, he's brilliant. This man's been a top government health official for, he's been in his position since 1984. He's brilliant. And even he didn't know everything because there's a lot we don't know. And I went to Austin for a friend's bachelor party the first weekend of March. And within a week of March, within a week of coming back, that's when the shutdown started. So like, that's how fast this escalated. And I'm very lucky because up in Buffalo, we had time to prepare because we saw what was happening downstate back home. So here in Buffalo, which is the second largest city in the state, we had time to prepare. So we had to increase our hospital capacity. I rotated at 3 different hospitals. One of them is the VA hospital in Buffalo. And luckily we were able to, mentally and, we had time to mentally prepare and to get the staff together.
So my question for you is, when a patient comes in, is there like an average story? Like, is there a consistency in like the way that people show up to the hospital and kind of explain what's going on, or is it different for every individual?
I'll be honest with you. I mean, I have not encountered a lot of the patients in the emergency room. I've been in the ICU on like once they come up.
Oh wow! So once it escalates.
Yeah. So what happens is a lot of them. So I think for a lot of them it's different. But I can tell you what I've encountered. I had a guy in the VA, in his 60s, multiple medical problems. His story was he'd been sick for a couple of weeks. He was having fevers and whatnot, but then he came into the hospital because his shortness of breath was getting much worse. So by the time we got him up to the ICU, he was on a special, it's called a high flow nasal cannula. It's a special, like, you know how you wear like a little oxygen under your nose?
Yeah.
It's a fancy one that usually requires you to be in the ICU. And we kept him on that. Unfortunately, he had to get intubated with the ventilator. And we were not in short supply of ventilators. The concern was Buffalo was going to have to send ventilators downstate, and we got nervous.
And is that like a last resort? Like the ventilator is like, if you absolutely have, okay.
So under normal circumstances, I mean, I use ventilators every time I'm in the ICU. I mean, I'm not scared of them. I used to be scared of them when I first got out of medical school, because just by turning some buttons, you literally like adjust the dial to adjust how you want the patient's lungs to breathe.
Wow.
You can potentially cause significant harm, but that's why you have to learn the physiology of it.
Do you think it's like intimidating, especially for new doctors, that now so many people need ventilators, that it's actually that's another issue that I haven't heard anybody talk about, because a lot of people think you just hook them up and it's 1, 2, 3 and that's it.
No.
But it's actually something that could be kind of intimidating if you're not familiar.
So there's 2 things. Yes, it's intimidating, but I'm a resident. I'm not an attending physician, so I'm not finished with my training. So I always have someone above me who I can contact for help. Even when I work nights in the ICU, when I was on nights at the VA for 3 weeks, even though I was the only person, I wasn't the only person there. I was the senior resident. I had an intern with me. I was able to call someone who was higher than me in ranking if I needed help. So let's just put that out there.
All right.
Residents have supervision. We have fellows and attendings who are above us who we can contact for help. But yeah, it's scary. If you're not comfortable with it, you're gonna be scared about it.
I mean, it doesn't sound like your hospital has the problem with like having to decide who gets one and who doesn't.
We never had that problem.
There's a lot of people that I'm hearing have that. In a situation like that, maybe you don't know because it's not something that you're dealing with, but in those situations, is it always like one person from a hospital or like a supervisor who makes that call, or is it just up to the people like yourself and the nurses, or like who decides what would get what if the resources aren't necessarily in abundance?
I'm afraid to answer that question. I've never had to deal with that. It would be above me.
All right. No, I'm just curious because New York.
I'll say this. We never had that situation in Buffalo. And to my knowledge, nobody was denied a ventilator if they needed it.
All right,
Uh,
no, great to know.
we put patients on ventilators all the time. It's not like an unheard of thing.
Okay.
And actually, with our COVID patients, we realized by April or so that what we did was, instead of intubating them and putting them on a ventilator right away, we tried to prolong the process of keeping them on the special nasal cannula or keep them on a mask, because there were some studies suggesting that, hey, if we wait longer to intubate them and put them on a ventilator, it seems that the outcomes are better. I honestly don't. That's based on what other doctors experienced in other parts of the state. Um, so normally, when we would immediately put people on the ventilator, we were saying, "All right, let's hold off. Let's wait another 12 hours and see how they do."
Okay.
And I'll get back to your point. You said once you put them on the ventilator, is it 1, 2, 3? That's it. Leave them alone. Wrong. No, because what you have to do is you hook them up to all. This is when you have to, this is when it gets really complicated. You have to make sure they have access for blood draws. That's first and foremost.
Okay.
And you have to keep watching their. Do you remember in grade school we learned about pH and acid base levels and stuff? Do you
I
remember that?
mean, I went to a way less respected school than you did.
Bro, it was on the New York State Regents.
All
So
right. I
anyway,
mean, maybe. Yeah,
all
it's
right. So let's go back in time. So we have acids and bases, right? So our blood has an acid base level, or the pH, that is supposed to be around 7.4.
okay.
When your respiratory system is compromised, or when you have a really bad illness, that acid base balance changes. When you are on the ventilator, we have to constantly, I'd say maybe depending on how sick you are, at least every day, depending on how stable you are or how unstable you are, check your acid base balance. In some cases, we can use the ventilator to fix that. In other cases, the ventilator can't do that. It's another problem that we have to deal with. Sometimes the ventilator pressures, because it's air, it's a closed circuit of air, the pressures might get too high. You have to change the settings to lower the pressure because you can cause lung damage. And the problem with our COVID patients is that a lot of them were not able to get weaned off the ventilator. They were staying on the ventilator for a couple of weeks, and they could not get off the ventilator. In most cases with other illnesses, yeah, they're on the ventilator for a couple of days, and then we can gradually get them off of it, and give it to someone else.
So
So that's
I
been the
want to
problem with COVID.
I want to rewind just a little bit because I mean it sounds like you're dealing with things that's at like the final stages, hopefully at that point you're coming out of it or God forbid,
Yes.
worse. But on the earlier side, we've got some knowledge of this now, and I think it's a little mixed as far as like who specifically it affects.
Sure.
We've heard things like underlying conditions. We've heard
Yes.
things like wear a mask. Can you just kind of break down maybe what things people can do to kind of prevent it or avoid it, I guess, to some extent, whether it be like
Sure.
boosting immune system and also, if you are somebody who does think that they have it, what's the best approach to get those first steps, to get the actual help that you need without putting yourself more at risk?
Okay. Who can get it? Anybody. Young, middle-aged, old,
And,
black, white, brown,
and real quick,
purple.
not to cut you off, have you seen people on these later stages of all different, like of everyone you mentioned, of all the demographics,
Yeah.
in the ICU, have you seen a child? Have you seen an adult? Have you seen?
I only take care of adult patients. I'm not a
Okay.
pediatrician. I haven't seen kids with it. And we have a children's hospital in Buffalo, Shy Children's. They've had very few cases, thank God.
Okay. But adult-wise, it's been all different nationalities, races,
Yeah.
everything.
Yeah, of course.
What would you say is the minimum, like the youngest patient you see and the oldest? It's anything from 18 to...
I personally didn't see any young people in the hospital with it.
Okay.
I have a friend who's dating someone who I went over to her home because they got scared. we presumed he was positive because he was really sick. He ended up having to go to the ER a few days after I saw him. He's fine now. He was never admitted. It's one thing to go to the ER. It's another when you're actually admitted to the hospital. People go to the ER all the time. It's the same thing as going to urgent care, but more expensive. So
well said.
Yeah.
So anyway, it could affect anybody, but
anybody.
Preventative wise,
him, the problem with him was he was in his late 20s. He's doing fine, thank God. But when I saw him, he just looked like, he literally was like, the poor guy was just exhausted.
All right.
But he couldn't get tested because at that time there was not enough testing. Now, thank God, people can get tested. It wasn't until maybe 5 weeks ago when you can actually get tested outside of the hospital. Prior to that, we were only able to test people who were symptomatic admitted to the hospital. If you showed up to the ER, Mike, saying, yo, I think I got the COVID, they weren't going to test you. They were going to send you home and stay home because it didn't really change your management, but now we can at least test you.
So at what point, my fault, I got a little sidetracked, but how can people prevent it? And if you do think you have symptoms, at what point do you go try and get tested for this?
Okay. So I think, we can't necessarily, as far as I know, at least around Buffalo, if you want to get tested, you have to have a doctor order the test for you. You can get the nasal swab, that's the PCR test you'll hear about on TV. I know they used all these fancy terms. So the nasal swab, you can get that done now because it sounds like the state has the capacity now to do it. You have to call your doctor. Don't run to the ER if you think let me step back.
All right.
If you think you've got COVID, let's say you think you were exposed, you think you've got COVID and you're symptomatic, call your doctor and they can order the test for you, and they'll tell you where to go. There are different test sites. There are outdoor test sites, like at least in Buffalo. I don't know how it is.
I've seen in Long Island too. I mean, I don't know. There's people that watch this from all over the world, but in America, there's been a couple of places. At least I should say in New York, there's been a couple of places like where you could just drive up and get a test.
And they do have that. And so that's ideally where you would probably go if you're having symptoms.
Okay.
If you are not having symptoms, then it's safer to go to like a Quest or LabCorp.
And what are the symptoms, real quick? Just because I think they've the most recent, current, up to date, knowledge on symptoms.
So, fevers. But again, you don't have to have all these symptoms, but these are because remember, you can be asymptomatic and be spreading it. And we'll get to the masks in a sec. Fevers, bone pain, just body aches all over, feeling really run down, just really exhausted. People have had stomach symptoms like diarrhea, hence the toilet paper crisis. Initially, we were all laughing, saying like, "Oh, what are they doing? You're not going to have the stomach problem with COVID." Well, it turns out, COVID patients were having GI problems or diarrhea, and of course, there's coughing. And that's because it is a respiratory virus. But not everyone has those symptoms. I know people who just had body aches and fevers, no coughing, and they tested positive for it. Or they just felt like a little sick, but nothing really, and they ended up having a positive antibody test. So those are, it sounds like the flu. But these are fevers that can last for days on end. There are guys in the ICU who I took care of who, after there was one guy I had, he successfully was taken off of the ventilator and lived, and he was still having fevers. Like, this is weeks after he got diagnosed in the hospital. So it's a very weird virus. We're still learning more about it.
Okay. As far as like the masks and things like that go, because now it's like become a thing where people are trying to reopen, which I definitely want to ask you about your thoughts on that. But as far as masks and things like that go, I think when this first started, they were talking about regular masks don't work, only N95s. Now it seems like really any mask is going to give you the pass to at least be outside. Are there masks that are like more effective, less effective? Are the most simple ones effective at all?
So before I answer that, just one more thing. The time when you do need to go to the emergency room is if you really you feel like you can't breathe.
Okay.
You feel short of breath, you can't breathe, you're breathing uncomfortably, that's when you go to the emergency room. If you're just feeling cruddy at home and you've got fevers, you don't have to go to the ER. You should call your doctor. Okay. You should call them because you might have something else going on that would require going to the ER, or you might think you have something that requires going to the ER that necessarily, where you don't have to go.
I have a little experience randomly. Not that it has anything to do with COVID, but right when this happened and people were starting to shut down, I had like a shingle randomly, which is like so uncommon for people.
Shingles?
I had one. I just had one pop up, and I called the doctor, and I went through the whole questionnaire about the COVID, right?
Yeah.
And basically they figured it's a shingle. I came in, they gave me a prescription to get everything sorted. Now I'm great. I'm chilling. This is like at the very beginning, I'd say 2 months ago. But I mean, when I called, it was just such a unique experience because, usually you call the doctor and it's just like, yeah, come in for an appointment. This instance, it was not that, like, that wasn't the case. It was very like, don't come in. Right. Don't come in unless it's like, after a while, they finally were like,
we were doing that so I have, for residency, we have a continuity clinic. We were doing that with our patients. We basically did all telephone visits or telemedicine visits. Okay. And that's another issue I was having. I personally thought it was difficult. Some doctors liked it. Others, like myself, think it's not. I just don't like it. Is it better for the patients because they stay home? Yeah. But not every patient, because a lot of my patients live in the projects, they don't have a computer. I can't, they don't have the means to go online and communicate me through a computer, or they don't know how to do it. And, you can't listen to them, you can't examine them. But yeah, we were trying to keep them out. Now, because it's better, we're having them slowly come back into the clinics, thank goodness, because now they can actually get seen. Now, with regards to masks,
So I have 3 examples here.
Yeah.
I have this bad boy.
That's a surgical mask.
Effective or not?
Yeah, well, so the science is saying yes. So
okay,
I would say yes, wear the surgical mask. Make sure when you wear it,
it's this one.
Mike, please put it on for me.
Okay.
Very good. So you're wearing it correctly. Your nose is covered and your face is covered. Very good. And it's folding and it's touching your nose. You're good.
So there's
Don't
still a
touch
little
the mask.
There's still some space on the side, but that's okay as long as the nose and the mouth.
Yeah, I mean, it's not 100%. Nothing is 100%. That's the N95 mask. You can't wear that mask. Do you know why?
Why not?
Because you have a beard.
Okay, so if you have a beard, this isn't the move.
No, it's not the move. If you have a beard, it's so 2 things about N95 masks. As a doctor and nurses too, and I should say any healthcare worker who's working in a hospital, you have to go through occupational health to get cleared to work. They do an N95 fit testing.
Okay.
You have to be shaved, and they have to make sure you're wearing the right size masks. There's a regular size and a small size. And actually, in Buffalo, we have a severe shortage of the small N95 masks.
This one.
Yeah, that might be a small. I can't see. N95, does it say an S on it? I can't see it from here. But there's a regular size and a small.
Okay.
So there are people walking around N95s, which are not the cheapest thing to make, and they're really high demand. We need those in the hospital.
Okay, I will mail these to you.
No, we're fine. It's okay. You know,
I have some that aren't used. If you want.
Why do you have? We're not going to get into that. You're not hoarding anything, are you?
Well, no, I'm not hoarding anything, but I bought like 3 packs of each kind.
People are buying them up, and here's the problem: you're buying them, and they may not actually fit you.
Okay.
Like, I can't wear a small. When I got fitted, I was like right now I got scruff. We've all been shaving at work because the N95 is not effective if you're not shaved. So
if you're bearded like I am, you can basically get away with this as long as it covers your whole face. It's effective.
If you're not, so if you're in the general public, yeah, that's totally fine. You don't need to wear an N95 mask in public.
Gotcha.
It's more important for the people on the first line to have an N95. Are the N95s more effective than surgical masks? Yes, they are. That's why we have them in the hospital. We have them in the ICU. Whenever we go into a COVID patient's room, we wear the N95. We are not wearing surgical masks.
Okay. But ideally, if you're, somebody that's just like myself, that isn't at a hospital at all, that doesn't have any underlying conditions.
You don't need an N95 mask.
Okay. Awesome. Great to know.
Surgical mask that you're holding up, hold it up. That's fine. That's perfect. A regular surgical mask.
They're also the cheapest, in case anybody's wondering. So
don't get ripped off. There have been these things are meant to be super cheap. Don't get ripped off because they're super cheap. Okay. I don't know where people are buying them from, but be careful. Don't get ripped off. All right. Money's tight for everybody. Don't get ripped off by them. And again, if you wear an N95, you have to technically be fitted. You shouldn't just pick an N95 out, wear it, and say, I'm good, because it may not fit you. And the other thing is people don't wear it correctly. An N95 is a complex mask. You have to make sure it's on the correct way and everything. So a surgical mask is fine, long story short. And when you touch the mask, you should wash your hands, because the virus and other crud from the air that you don't want to breathe in is on the mask. So that's why you shouldn't touch your mask. Don't touch your face. Don't touch the mask. Wash your hands. Wash your hands. Wash your hands. And use hand sanitizer if you have hand sanitizer. That's fine too. Okay. That's how you can keep yourself from getting sick. You do not need to wear gloves when you're going food shopping, because when you're wearing gloves, you're touching your phone, you're touching your wagon, you're touching stuff that's going in your cart. It's sort of a farce.
You're still just spreading everything.
You're just spreading it. So the best thing is don't wear gloves. Just wash your hands.
Well, it's not don't wear gloves, but either way, it doesn't make a difference, it sounds like. So if you're wearing gloves, you're not really doing anything, but just...
No, it's still, you're going to move the virus around. You're going to move bacteria. Remember, there's bacteria too.
All right.
I'm not, gloves are meant to be worn for a very short period of time in one room. When you finish seeing the patient, take the gloves off. I'm not wearing gloves from patient to patient. That's gross.
All right.
I wash my hands in between patients, right? So why should you?
No, you said it perfectly. Gloves? I think they're meant to be worn one time in one room.
Yeah, pretty much. Yeah.
What are your thoughts on I'm sorry, my fault. Go ahead. I didn't mean to cut you off.
No, that was it.
I would say, what are your thoughts on reopening? Because I think there's a very, there's two sides. It's mixed opinions, right? And some people are like, open. Some people are like, don't do it. Yeah, as a professional, do you think that there is a reasonable way to open in a timely manner, or do you think we're going to be dealing with this for a little bit longer and staying closed is the best option?
I mean, I think if you watch, look, you don't have to watch Trump's press conferences if you don't like him, but you should listen to his experts, who are the real experts. I trust Dr. Birx, Dr. Fauci, and folks from the CDC on their recommendations. And so the states are following the CDC's recommendations. So Governor Cuomo, he's been more conservative than some other states. And some other states have opened slowly, and they're doing fine. The thing is this, you're going to see more cases for two reasons. Number one, we're testing more people. If you're testing for something more and more often, you're going to see more positive results. If more women get tested with the mammogram for breast cancer, you're going to find more breast cancers.
All right.
Same with guys who get prostate cancer checks, and that's another story.
Yeah, the more you look, the more you find.
Yeah. But yeah, as you reopen, are you going to see more cases because of social contact? Yeah, you probably will. I'm sure you will. But that's expected. But and I pray that we don't have the spike like we did a few months ago. I think social distancing, as much as it honestly, I'm tired of the term because it's gotten so old. I'm speaking as a person, like social distancing, that's not what we are. We're human beings, man. We want to be close together. We should be using Zoom because I'm in Buffalo, you're in New York.
Yeah.
That's why we're using Zoom. But otherwise, technically we should be hey, I'm around the block, but we're
Yeah,
not
the
talking
same room
Zoom.
for sure.
So social distancing has played a role. It and you can still do it if the economy is opened, but we have to just be careful for the next until we have a vaccine.
Okay.
It,
So that's my next question is there a reasonable timeline, do you think, like that we could expect something like that? And also, now that people are getting tested for the antibodies
yeah.
and you know, say some people find out that they can't get it, that they do have the antibodies, do those people still go wear masks and social distance, or are those people
They
pretty much
should. They should.
okay?
Because a lot of those antibody tests have not yet been approved by the FDA. We still do not know if it gives you full immunity. We don't know because viruses can mutate like the flu. The flu mutates every year. Because you get the flu one year, you can still get a different strain of the flu the following year, but you get the vaccine for the flu every year. At least you should. And now people know what it's like, by the way, to live in a world without a vaccine. This is why we were aggressive, and I'm glad New York State was aggressive with this. When we had the mumps and measles outbreak down, I think it was Westchester and Brooklyn, you know, they were not vaccinating their kids, and there was a lot of measles going around because they weren't vaccinating their kids. How did you quash the problem? You vaccinated people and you isolated the sick people. So I hope people get vaccines. I know people are scared to get vaccines, but the benefits outweigh the risks. You should get a vaccine if a doctor tells you to get one.
So as far as a COVID vaccine, is there any conversation about that, like in the medical world?
Are.
What's
so
about the timeline, I should say?
Ideally, it takes. I mean, usually it takes well over a year because you need to develop a vaccine that has been shown to kill the virus. You need to test humans to see if they can mount an immune response, which is that IgG testing. Can you get good IgG levels from the vaccine that they're making? Is it safe? What are the side effects of it? How long can you keep that immune response for? These are all things that you need to have to get tested before it's released to the market, you know, and then on a mass scale. So they're saying, oh, we can get a vaccine by the end of the year. I'm very skeptical about that, but I'm not a vaccine expert. I'm not. I'll come out and say it. I'm just going by what, you know, I've learned about vaccines over the years. Vaccines are not an overnight thing. So even if you test positive for the antibody, and you've been, you know, you might be immune, you might not. You could maybe get it again. I think there's not enough evidence out there yet. So if you had the COVID, you tested positive, and you recovered, or if you were asymptomatic and you tested positive for the antibody, you still have to act as if you can still get it and that you can still spread it, which is why you wear the mask and do the social distancing. That's the long answer. So I'm hoping they can have a vaccine in the next year that's effective. I don't want them to come out with a vaccine that doesn't work. No one wants that. But the vaccine is the best way to have what we call herd immunity, where enough people in our population are immune to it. So people who are vulnerable, like our cancer patients, our elderly patients, or people who didn't get the vaccine, that's when you can go out and not worry about it because enough people are immune to it. That's the safest way to get herd immunity. And we're far from herd immunity because we don't have a vaccine. And, you know, I'm hoping we can get it.
Yeah, no, it's just going to take time, it sounds like.
It will take time. Don't be shocked if they don't have a vaccine ready this year. They're testing people. They have actually inoculated a lot of volunteers. And I know that the government's recruiting thousands of volunteers to, you know, hey, inject that vaccine into me. That, you know, that's how you do it. I mean, you have to test people, but, you know, that's what clinical trials are for. That's the safest way to do it, is to do clinical trials. Don't rush things. At the same time, you know, we are kind of rushing because of the, because the situation's dire. It's really, it's not
It's
ideal.
going to be a process, and I think we still have a lot to learn. But I mean, ultimately,
we have a lot to learn, and we're learning more every day. We're learning more about what treatments work and what treatments don't work. I know that there was something, the thing with hydroxychloroquine. Well, they basically said, all right, well, that's not really proven to help with coronavirus. What about preventing coronavirus? They don't really have enough studies about its effectiveness in preventing coronavirus. So that's something that we've learned, but notice how it took a couple of months, right? We were talking about in March, and we were like, oh, this is the next big thing. Well, then we had time to study it. Now we're testing remdesivir, which is something you get in the hospital. And some studies have come out saying it can help people if you're already sick with it. But again, you need data, and data takes time. Data is not overnight. If you want to do a good study, you need months and sometimes years, depending on what it is.
And that's the thing, guys. I mean, if you're watching this, I think you got to understand that, they need time. We need patience. And it's super important that, we have patience and we bear with, whatever the CDC is saying, whatever the World Health Organization is saying.
I think, I think we can reopen, but we have to be, you have to be smart about it. You have to, look, I hate not shaking people's hands. It's second nature for me to shake people's hands.
Yeah, it's very.
And I'm not shaking. We're doing elbow bumps. And it's like, but that's what you have to do. These are things you have to do for the time being. Because, by the way, why is it 6 feet? It's 6 feet social distancing because that's how far germs can travel when you sneeze or cough. And again, masks or no masks, when you're not wearing a mask, especially, cover your sneezes, cover your cough, sneeze into your arm like you're taught as a kid. Wash your hands.
Don't touch your face.
These are things we were taught as kids, and honestly, I wasn't the best at that.
Yeah, this guy lost his shoe in a pond. We'll save that story for the next time, though.
Yeah. And the thing about masks, again, masks are not really meant to protect you. It's more to protect people around you, which will in return protect you. In the operating rooms, surgeons are wearing masks. The patient's not wearing a mask. You're wearing the mask to protect the patient.
Yeah.
The patient's vulnerable. Their body's opened up. You're trying to protect them. Everyone in the OR is always practicing social distancing, technically, because they're wearing masks. They've got gloves on, depending on what they're doing. And it's for not necessarily for them. It's more so for the people around them, especially the patients. So you wear the mask or the cloth, whatever you can get. I mean, it's not 100%, but it's something. You wear it for other people. And it's mainly for when it's mainly for when you can't be more than 6 feet apart. If you're 6 feet apart, then you necessarily don't need it. If you want to wear it, then go right ahead and wear it. But when you go food shopping, you should wear it because, the grocery stores,
there's a lot of people, especially now. I feel like there's more traffic in them than ever.
Yeah.
Faber, I really appreciate your time, man. I'm super proud of how far you've come, man. And
I'm proud of you too, brother. I miss you.
I miss you too. We will we'll talk more. I'm gonna wrap up the interview. If y'all want to keep up with Faber, ask him questions, anything like that, make sure you have the right insurance card. You want to shout out your Instagram or a place people could, keep up with you?
I have a professional Twitter account. How about that? Okay.
So y'all can follow him on Twitter. Do you do any updates? You ever tweet anything?
I'll tweet medical stuff. I'm not tweeting personal stuff.
That's what we're looking for. So shout your Twitter, let them know where to keep up with you. And when this guy moves back to the city and opens his own practice.
There you go. My Twitter is at Mark Faber DO. I'm actually not an MD. I'm a DO. I'm a doctor of osteopathic medicine. Little difference.
Is it more lit or less lit?
It's more lit. Man.
Okay. All right.
Same licensure exams, same license. But yeah, that's my Twitter handle.
I'll take it. Thank you so much, Faber.
Love you, brother.